What I'd like to do today is we're going to start by talking about making successful clinical decisions in clinical practice. It's a very wide subject. We're going to really focus it down, as you'll see when we go. Throughout the year, though, we're going to also talk about treatment planning and with other webinars specifically dictated to that, and we'll be able to really talk about clinical decisions in a much more intense fashion. For today, what I'd like to do is share with you some ideas about making clinical decisions based on what the components of aesthetic therapy and outcomes are all about. Are they about just the ceramics, like we have in standardized restorative dentistry? We share a lot of what the expectations are, which is an outcome of a restoration that blends in with the natural dentition in a way that cannot be realized and picked out. The aspect, however, is that it's not all about the ceramics. What we'll find out today in this discussion, and I look forward to the question and answer period, is that really in the components of dental aesthetics have a lot more to do than just the ceramics or the ceramics that we utilize. They really have a lot to do with the understanding of the frame and the foundation that restoration gets put in. So it involves the dental facial aesthetics, the bone, the teeth, the lips, the face, and how they come about together. Only when all of those are in harmony and actually follow the principles of aesthetics are we able to really deliver an optimum, a highly aesthetic restoration, whether a single unit or a full mouth reconstruction. If you take a look at, for instance, these presentations by some of our patients that we'll talk about a little bit, it's obvious that even the best ceramist will not be able to create an optimal aesthetic restoration for some of those on the lower row of your screen. It requires a lot more. It requires for us to develop a protocol and understand all the components, the bone, the soft tissue, the relationship of implants to those tissues in order to optimize them. In our practice, what we like to do is to first off, and many of you have seen me present this, is something we've literally been utilizing for over 15 years. We look at cases and classify them in three groups. The type 1 case is the ideal case. We have good quality of bone and soft tissue, a good volume. And in this particular type of environment, our main goal as clinicians is to preserve this type 1 site. This is where we can do our best work. In the type 2 site, this is defined mostly as a labial defect, buccolingual or labial defect of bone and soft tissue. It could be a recession defect. It could be a ridge defect, as you see on your middle screen. It could be a loss of the labial plate due to trauma or periapical pathology. It could, of course, be a type 3 site, and type 3 sites, as we classify them, are predominantly interproximal defects. These are the most difficult, the most challenging to treat. They have vertical components, and by definition, because it's interproximal, it usually will have to require the treatment of at least 2 or more teeth. In reconstructive dentistry today, our goal and how we follow and create treatment plans generally requires us to preserve type 1 sites when we have them. We utilize surgical and restorative modalities to do that. And for type 2 and type 3 sites, our job is to reconstruct them, augment them, develop them so that they can, again, become type 1 sites. And that is the general sequence of therapy and the general goal and emphasis that we put in our treatment plans. Diagnosis is very critical. We use many means, digital radiography, as well, of course, as clinical exams and models and wax-ups to make our determination. Yes, we have a lot of tools, and we'll be talking a great deal about that in terms of biotechnology. We have new grafting materials, acellular dermis, certainly BMP and growth factors are available to us. And that aspect of the tools that we have will be discussed a lot more in future webinars. We have digital technology. In addition, both to virtually place implants, CAD/CAM technology, shade taking, all of these have helped us to really bring the best that we can to our therapy. We're going to focus today, however, in my role and what I've been asked to do today by the Dental XP board was to talk about the role of implant and abutment design, and specifically interface development around where the abutment and the implant come into contact and connect. And that the way clinicians have to look at it and how we look at it in our practice in order to make decisions to do it. There are many implant designs out there, from transmucosal, certainly to even one-piece, many abutment systems. What are the requirements? How do we actually choose implant designs, both macrogeometry and microgeometry, in order to enhance our final results? Very key element for us as part of the diagnostic phase, as you just saw, is to identify the restorative recipient site. In this particular case, of course, it's a single unit. It's a type 1 site, as we've discussed. This is an ideal environment. And for us, the goals here, of course, are the same as it would be for a patient coming in requiring a veneer or a single unit crown, as an example, to level out and create harmony in the gingival margin and the height of the papilla to blend in ideally with the adjacent dentition. A key aspect, though, that only really became critical, and we really focused on it a lot more recently over the last 5 to 10 years, has been color, tissue color. And not only do we have to have it when we cement on the crown, but it has to be durable, it has to have longevity, and it's the only way that we truly can blend implant supported restoration with the natural dentition and to be able to achieve optimal aesthetics. But in addition to our successes, we've also seen failures, aesthetic failures. They're really the main challenges. And anyone who's been doing implants for a long enough period of time has had these experiences, or certainly has had patients referred to him that have had these difficulties. Aesthetic failures started immediately after we started to place implants in the partially edentulous patient. And they're not all the same. Some failures, as you see highlighted here, interproximal. There are interproximal failures. There are failures on the labial aspect that include recession, color changes, and may be related both to inadequate bone and soft tissue handling or inadequate restorative components. That's the area that in this hour that I'd like to share with you, that I'd like to focus on, is the labial aspect. We'll have more time to talk about the interproximal components of treatment a little bit in the future. But the labial aspect, and specifically, if we take a look at this component, as you see here, in the late 80s, early 90s, when we were thinking about implant dentistry and taking a type 2 site and a type 3 site, we talked about implant site development. Today, in 2011, we really have evolved to really look at these sites enough with the knowledge, the scientific knowledge, and the research backing to be able to say that today we treatment plan and diagnose based on interface development. The failures that you see in that screen where the arrow is pointing, on the labial in particular, have to do with the bone, it has to do with the tissue, it has to do with the restorative component. What can we do as clinicians to prevent this from happening and to choose the therapy that will allow us to not see too many of these, because obviously it doesn't take too many like this to really ruin one's practice. So when we look at this patient in front of us right now and think about the reasons that may contribute to recession and specifically color changes, this is a young lady that had implants placed in the lateral incisor area where she had agenesis of the laterals. And about a year after the final restoration was cemented, she comes in, she was 19 years old, with a complaint that the tissue, the gingival marginal tissue, is getting darker and darker. Very critical aspect, of course, especially as it relates to the aesthetic display of this patient. So when we look at it in many ways and in many practices, especially a low lip line type of patient, this would be a successful case. The gingival margins are in a reasonable position, and the papilla height is in a reasonable position. The problem and the failure of this case, though for this particular patient, is the color changes that have occurred in those receptor sites. What went wrong? What were the problems that led to this? The first aspect I'd like to suggest to you, where the interfaces really weren't handled properly. They weren't diagnosed properly, they weren't handled properly. And in this particular area, because of the agenesis, because there were never any deciduous roots in there, we were able, the ridge never actually developed. The root eminences never really developed. So you have a concavity there. But because there was enough bone to place the implants, the clinician placed the implant, and we're able to get osseointegration and get the restoration on here. But they didn't create a durable, long-lasting implant soft tissue restoration interface. And what I'd like to suggest is that in many ways, this was treated as a type 1 site. It was treated minimally invasive. But in fact, this was a type 2 site because you have a labial concavity. And the type 2 was never dealt with. The concavity in that area, light goes in, doesn't come out. You have shadowing, and certainly compromises the display of the restoration. When we raised the flap in this case, it's what we expected. You had bone loss of the first thread, and you certainly look at a situation where now the head of the implant's actually exposed, and that the titanium now bleeds through the thin tissue, which is another part of the diagnostic process. What happens? This is something that's been around and well understood for over 15 years now. When the implant goes in, even in a thin ridge, as you see here, it looks okay, and the osteotomy is intact, but we have a very, very thin ridge, or labial plate, I should say, that's remaining. What happens? This is very well known and documented. You put in your abutment or healing abutment or restorative abutment, and because of the inadequate thickness of bone, and we know this from the work of Grunder and Danny Boozer and others, that we need 2 millimeters. A case like this probably only had 1 millimeter. When we actually add this about a month or 2 later, or a few months later, you will have remodeling of the bone to the first thread. That's the biologic width effect that Cochran and Herman and others have discussed. What can we do about it? How can we overcome that if we do see a ridge, as you see on the lower right part of your screen, where you can get the implant in, but the labial plate is very, very thin? Well, some of the way we're handling interface development today is we're grafting those areas. We're doing osseous grafting, usually with a low turnover grafting material, so that it would create the ability to create a scaffold for the soft tissue. We also are doing soft tissue enhancement and grafting when the tissue is very thin. So these are aspects that we can utilize when we understand about interface development in order to anticipate the biological changes that occur at these interfaces. What else can we do? Macrogeometry, we can choose an implant that incorporates platform switching. There are several implants out there. We also need a connection that's a rigid connection, that's almost invisible to the body. And this gives us several advantages. What happens is now, not only do we have a rigid connection and no micro movement, we also have a bacterial seal that will prevent bacterial leakage in there in many cases. And also, we're going to have a further distance between where the abutment actually leaves the implant and the labial crest. So now you're increasing the distance of effect that will occur in terms of that particular area. So those are some of the different approaches from a interface development that we're utilizing. For our case and what we're trying to do, I'm going to discuss with you today the interfaces that involve the head of the implant and abutments, and of course also the design of the abutments. We're going to look more and more how the abutments actually leave the implant. It's very critical that we don't over-contour our abutments and restorations. That taxes the soft tissue. So abutment design subgingivally is very, very critical. Abutment connection to the implant is also critical, and I think that's been very popular and addressed by many different implant systems out there. This one that's on display right now, that's the Ankylose from Dentsply Freedom. And what did we do for this case that I started to present to you? In order to correct it, obviously we weren't going to take out the implant. We wanted to do something to really change the display of that implant within the aesthetic zone. So we grafted it. We took a large connective tissue graft from the tuberosity area and tried to thicken that tissue. So it's a combination solution. We're going to use soft tissue augmentation, and we're going to use ceramic abutments to change the display in that area. And as you can see, what we had started out was a concave environment, and now we change it to an environment that's thicker tissue and that's in harmony with the light properties of the adjacent root concavities. And this is very, very critical, and I'd like to share with you an excellent article, one that's really affected a lot of what we do and how we design these particular interfaces. This is an article by Ronald Young out of Zurich, and the most recent one published in IJPRD in 2008. And they talk about, in this article with Dr. Young and his team, is the effect of tissue thickness and abutment materials and design on the color of the soft tissue. It's a very elegant study, and what they showed is they took the same implant in the same mouth and put either a ceramic abutment or a metal abutment in that area, and they measured it in that same area in a very objective manner utilizing a spectrophotometer. And they also compared it to the adjacent natural tooth to see the color changes. And the conclusion from both the in vitro studies and the clinical studies was that tissue thickness and abutment material, whether ceramic or metal, really affected the color display of the soft tissue. Many of us probably can certainly have guessed on that, but now we have critical objective measurements from the scientific community that guides us in making decisions. What are those decisions for that interface? From an abutment standpoint, if we have tissue thickness of more than 2 millimeters, it doesn't really make any difference if we utilize a ceramic abutment or a metal abutment. The color will be equally good in both situations. If we have thin tissue, less than 2 millimeters, then a ceramic abutment will be much more advantageous. And if we have, and restoring an abutment, an implant next to a natural tooth, we would want to have a ceramic abutment that mimics the shade of the adjacent tooth so that the ceramics can build up the porcelain in even thickness and in even shade matching. Back at this lateral incisor case, you can see that we were able to plump out the tissue, utilize ceramic abutments, ceramic crowns. So this was both a surgical solution of thickening the tissue with a soft tissue graft and also a restorative solution. Changing the abutments to ceramic allows us to change the display. Everything else being equal, the same implant, same natural teeth, nothing was done to them. You can see that the display with a high smile line that shows those gingival margins is now at a much healthier environment. And all it was really looking at that 4 or 5 millimeter distance of the different interfaces that we as clinicians, both surgeons and restorative dentists, have to deal with by making the decisions properly we're able to change how the patient came in complaining on the left with display that was more durable and certainly something that's much more aesthetic as well.